Let's learn CTGs together, and in this video we are doing it together, growing, refreshing our knowledge, sharing our experiences. If you have ever looked at a CTG and thought, I'm not sure what I'm seeing here, you are not alone. Let's break it down, let's make it simple. And if you have ever come across a tricky CTG scenario, maybe something that caught you off guard, or maybe something that made you second guess yourself, share it in the comments. Let's help each other, let's support each other, and let's grow together. In this video, we'll look at the basics, what to look for on a CTG, how to understand the features, and some of the everyday examples to make it stick. Then in the next episode, we'll go deeper. We'll look into complex patterns and real-life clinical situations. Let's do this. Let's refresh our knowledge together. The first feature that we are going to look at is baseline heart rate. This is the average fetal heart rate over a 10-minute period, ignoring accelerations and decelerations. Normal baseline is 110 to 160 beats per minute. If it's above 160 beats per minute, lasting more than 10 minutes, then it's tachycardia. And if it's below 110 beats per minute, lasting more than 10 minutes, it's referred to as bradycardia. Let's simplify it. Let me give you an example. Imagine a baby cruising at 140 beats per minute. If it stays around there with some little wiggles up and down, that's your baseline. Now, if the heart rate jumps up to 170, then it comes back to 140 in about 2 minutes. That's an acceleration. Baby moved or baby kicked. That's perfectly normal. But if it stays up there for more than 10 minutes, then that's not an acceleration anymore. That's now a new baseline, and we'll call it tachycardia. Same thing. If the heart rate drops, say it drops to 100 beats per minute, if it bounces back within a few minutes, that's just a deceleration. If it stays low for more than 10 minutes, that's a bradycardia, and again, that becomes your new baseline. If there's a bradycardia for 3 minutes, and that is classified as acute hypoxia, we'll look deeper into that in the next segment. Now, let's talk about variability. I can actually hear my midwifery tutor's voice in my head right now teaching variability. Beat to beat variation. My go show me. And back then, we were using peanut fetoscopes, just listening to the baby's heart with the peanut fetoscope, and she would ask you, can you hear the variability? And if you have done that, you know what I am talking about. You can relate. Some beats are sharp, some are soft, some are slightly slower. That's the baby's fetal heart telling you, I'm okay, I'm active, my brain and nervous system are working. So on the CTG, we want to see those little ups and downs, about 5 to 25 beats difference from one beat to the next. If the trace is too flat, the baby might be sleeping or it might be struggling. If it's too erratic, it might be stressed. Now, let's simplify variability. Imagine a car on a highway. If it's driving perfectly straight with no small adjustments, something is wrong. The driver might be asleep or the driver might be dead. But if it's making tiny regular steering adjustments, it shows someone is alert. That's what variability tells us. Baby's nervous system is awake and active. Reduced variability can mean sleep cycle or medication effect, or even hypoxia. Absent variability is worrying. Too much variability can be due to acute hypoxia or fetal activity. A pro tip: if the trace looks too flat, the baby could be sleeping or struggling. If it's very jagged and erratic, think stress. Now let's look at accelerations. This is a temporary increase in fetal heart rate, at least 15 beats per minute above the baseline, lasting more than 15 seconds. This is a sign that we have a healthy baby. Accelerations are reassuring. That shows that maybe a baby is moving, baby is kicking, and then the heart rate will rise. That's what we love to see. Let's simplify accelerations. When you climb stairs or when you get excited, your heart rate jumps a little. That's normal. For the baby, accelerations are like mini workouts. Baby kicks or moves and then the heart rate rises. That's a good sign. Next, let's look at decelerations. These are temporary drops in the baby's heart rate. Just like adults, babies don't keep their heart rate constant all the time. Sometimes it dips a little and it comes back up. On a CTG, a deceleration is when the baby's heart rate goes below the baseline for a short time, then it returns to normal. Some decelerations are normal and harmless, especially if the baby recovers well. Others might be a sign that the baby is not coping well, especially during contractions. So when we see a deceleration, we don't just panic. We ask, when did it start? How deep was it? Did it recover quickly? And does it keep happening? The answers to this will help us figure out what kind of a deceleration it is and whether it needs action or not. Now let's look at different types of decelerations: early, variable, and late, and what each one means. So for easy understanding, we are going to answer those 4 questions that I've discussed so that we understand each type of deceleration. The first question is, when did it start in relation to the contraction? Number 2, how deep was it? Number 3, did it recover quickly? And number 4, does it keep happening? Let's use these questions to understand each type of deceleration in a way that's easy to remember. Early deceleration, when does it start? It starts at the same time as the contraction. How deep is it? It's usually shallow. Does it recover quickly? Yes, it returns to baseline by the end of the contraction. Does it keep happening? It might, especially during active labor or second stage. This one is due to cord compression. It's often abrupt and sharp, like a quick trip over a wire. It involves both baro and chemoreceptors. Some variables are okay, but if they are deep, prolonged, or frequent, we worry. Late deceleration, when does it start? It starts after the contraction starts. There is a delay. How deep is it? It can be mild or it can be deep. Does it recover quickly? No, it recovers after the contraction ends. Does it keep happening? If it does, that's a red flag. This is due to placental insufficiency, meaning the baby is not getting enough oxygen. It's a chemoreceptor response. If late decelerations are repetitive, we must act. This baby may be struggling. Now, just like we said, an acceleration is a rise of about 15 beats per minute, lasting at least 15 seconds. A deceleration follows the same principle, just in the opposite direction. So a deceleration is a drop of at least 15 beats per minute below the baseline, and it must last for at least 15 seconds for it to be significant. If it lasts less than 15 seconds, then it's not counted. But if it goes longer than 15 seconds, then we start paying attention. Now let's go a step further. Prolonged decelerations. If a deceleration lasts more than 3 minutes, it's no longer just a typical deceleration, it's now bradycardia, and that becomes a prolonged deceleration, and we start thinking about acute hypoxia, a sudden lack of oxygen, and that's really a red flag. If it lasts more than 5 to 6 minutes, we treat it as a category 1 emergency. Call for help, prepare for urgent delivery because the baby might be running out of time. I think you just need to call for help as soon as you have a prolonged deceleration. Not wait for the 5 to 6 minutes because people need time to act. Now, let's simplify decelerations early. Imagine gently squeezing a stress ball. It compresses but it bounces back. Early decelerations mirror the contraction and shows the head's getting pressure but baby's coping well. Look at this. Now, let's simplify variable decelerations. Think of it like a hiccup in the baby's oxygen flow. Imagine you are drinking through a straw and then someone suddenly squeezes the middle of the straw. The flow stops for a moment and then it returns quickly once the pressure is off. That's what happens in a variable deceleration. The umbilical cord is squished, maybe by the baby's head, foot, or maybe a contraction. And then the fetal heart rate dips suddenly. But once the pressure is gone, the baby recovers just as fast. Now let's look at two important reflexes that causes decelerations: the baroreceptors and the chemoreceptors. These are part of how the baby protects itself inside the womb. Baroreceptor decelerations. Baroreceptors are pressure sensors. They react when there is too much pressure on the baby's head, like during a contraction or in the second stage of labor when the head is deep in the pelvis. It's a quick reflex. The baby says, "Wow, too much pressure," and the heart rate briefly slows down. These decelerations are usually shallow and short, and they recover quickly. It's the body's way of maintaining stable blood pressure. Think of it like pressing the brakes slightly and then releasing just to adjust. Chemoreceptors, on the other hand, they are oxygen sensors. They react when there isn't enough oxygen. This could be from a long contraction, cord issues, or placental problems. It's a slower, deeper response. The baby says, "I'm not getting enough oxygen." So the heart rate drops deeper and takes longer to recover. It's the body's way to try and preserve energy and reduce oxygen use, like switching to low power mode when your phone is running battery low. So this is an easy summary. Baroreceptors, pressure, fast and shallow decelerations, quick recovery. Chemoreceptors, oxygen lack, slower, deeper decelerations, slower recovery. In baro, it means too much pressure. Chemo, I need more oxygen. Right, now let's move on to contractions and their effects. Each contraction affects blood flow to the placenta. If there are too many contractions, hyperstimulation or tachycardia, this might cause fetal distress. Hyperstimulation is when the contraction lasts more than 2 minutes, and tachycardia is when we have more than 5 contractions in 10 minutes. So the more contractions we have, the less the recovery time and the higher the risk of decelerations. Now let's simplify contractions. Each contraction is like someone squeezing a garden hose. Blood flow to the body is reduced briefly, and too many squeezes, there's not enough time to recover, and then the baby gets tired or stressed. Now let's look at rise in baseline. This may indicate maternal pyrexia, infection, fetal stress, or medications like terbutaline. If the baseline slowly creeps from 130 to 160 beats per minute, think fever, think medications, think stress. Just like your heart rate rises when you have a fever or when you are dehydrated, a baby's baseline can also rise with maternal fever, stress, or infection. And now let's look at cycling patterns. Cycling, these are normal changes in variability over a period of time. Sleep-wake cycles. Absence of cycling over a long period of time might suggest fetal compromise. Baby's heart rate is not static. There are some naps and there are some active times. If there's no cycling, it's just like someone being unconscious, not just asleep. And we also need to pay attention to second stage CTGs. There's more pressure, more pushing, that will lead to more decelerations, but they should recover quickly. Some decelerations in second stage are expected, but the stress must still recover in between. If there's no recovery, you should worry. Now let's look at the wider clinical picture. Always ask yourself, what's happening with this woman? CTG is just a window and not the whole house. These are the most common factors that affect CTGs. Oxytocin. It leads to stronger, more frequent contractions, and this would lead to a risk of tachycardia or late deceleration. Maternal pyrexia might lead to fetal tachycardia. Antepartum hemorrhage could be as a result of placental abruptio, and it leads to late decelerations, bradycardia, and reduced variability. Epidurals, they might lead to maternal hypotension and will lead to reduced placental perfusion. Uterine rupture will lead to a sudden deceleration, loss of contractions, and an abnormal CTG. Also, a cord prolapse. This will lead to a prolonged bradycardia. Infection or chorioamnitis. This might lead to fetal tachycardia, reduced variability, and some medications, like I mentioned before, terbutaline can cause fetal tachycardia. So whenever you see fetal tachy, a rising baseline, acute hypoxia, just ask yourself, what could be the cause? What could have led to this? Key takeaways. CTG is not just a graph, it's the baby's language. Learn to listen. Ask, what's the baseline? Is the baby coping? Are the contractions too strong? And always relate CTG to the full clinical picture. Hope we have learned one or two things. Before we wrap up, I want to hear from you. If you are a midwife, a nurse, or a student, or anyone working with CTGs, please share your tips in the comments. Pro tips, quick ways to remember features, real life scenarios, anything that might help someone else understand CTGs better. Let's support each other. Let's grow together. In the next episode, we'll dive deeper into the physiology of CTGs, talking about how the baby compensates when they start to decompensate and what it looks like on a CTG. We'll also look at more complex stresses, real examples, and clinical decision making. If you haven't subscribed to my channel, please kindly hit the subscription button. Leave a like, comment, and remember to share this video to anyone that you think might benefit. See you in my next episode.